Welcome to the JEMS Report, brought to you by Clarion Events, Fire and Rescue Group, and the Journal of Emergency Medical Services. My name is Ted Lee, and I'm the Editor-in-Chief of JEMS Magazine. Along with Jeff Frankel, our Managing Editor, we will be bringing you subject matter experts and industry leaders in all things pre-hospital medicine. And today we have a very special guest coming with us from Florida, Dr. Christine McGuire-Wolfe from the University of Southern Florida. Thank you for joining us today.
Thank you, Ted.
So just to give our audience a little bit of your background and kind of who you are, if you would, because your email line has like several lines. So I know you wear a ton of hats, obviously, in what you're doing. So a little bit of context for the listeners would be great.
Okay. I'm currently an assistant professor at the College of Public Health at the University of South Florida in Tampa. I'm also the director of the Infection Control for Emergency Responders Collaborative and Training Hub.
So, and that's that one, short, the mnemonic for ICER, I guess is how you say it. Is kind of why we're here today to talk about that, because, before we got in contact, I really, wasn't aware of this program or kind of what your mission is. So, if you would go into a little bit of background about, what you guys do there, where it came from, and why it is so important.
Okay. So I retired from the fire service back in 2020 after approximately 18 years. And a good portion of my time there was as an infection control officer. So I had an interest in infection control in the fire service and EMS. ICER is a CDC-funded project. And really our main goal is to evaluate what training materials are out there relating to infection prevention and control that are specific for fire and EMS, and then to create resources that better fit the needs of that population. Most of the existing infection control resources are guidance that was developed for the hospital setting or for a traditional healthcare setting, and then adapted after the fact to fit the needs in the pre-hospital setting. So ICER's main goal is to address the issue from a true pre-hospital care setting perspective.
Yeah, and given your background in history, I mean, I know this as well, that, a lot of the stuff that we've done throughout EMS history has been, well, if it works in the hospital, it must work there. If it works here, it must work there. And, we always ran into problems. We didn't have funding. We didn't have equipment. We didn't have, all the resources. And, trying to keep up with or even meet some of the goals or requirements, we're like, we don't have the resources for this. I mean, a lot of the smaller departments, infection control officer is also assigned, but you're a medic or, a firefighter on a truck, and you've got a million other duties. So how are you supposed to do this? So this is designed to help those, right?
Yes, it's often the infection control officer becomes the infection control officer because they get promoted to something like health and safety chief without having a true dedication to the topic or even a background or knowledge of the topic. And so, again, part of our mission is to develop some standardized training materials for those sorts of roles. As we work on, collecting background information about the current status of the issue, it really is not standardized, across the nation, in between departments, what the qualifications are to become an infection control officer, but also once you're in that role, what sort of continuing education or resources are available to those individuals to help them fulfill their role in an effective and competent manner.
So this is a fully encompassing type thing. So if I'm new to the role, not only do I get help with how to train individuals, I'm getting training as well, or education in the realm of infection control.
Right. And really, in most agencies, the infection control officer is also tasked with supplying training for field personnel about infection control. Sometimes it's assigned to the training division, but typically it's with an infection control officer. So if those individuals don't have the background knowledge, and they're responsible for training their personnel, it creates a bigger gap. So we're creating materials specific for field personnel, but also support for infection control officers so that they're able to pass that knowledge on to the rest of the agency.
So when you mentioned that you're creating training, I mean, what forms of training, or can you give a few examples of, what you guys are working on?
So where we are right now is we have some national surveys out to field personnel. Again, in the past, field personnel input hasn't been incorporated. And that's really one of ICER's priority, is to get that input from the people who are going to be using the end product. So we have not yet developed materials. We have surveys out to find out what are the best ways to deliver material, what specific topics are field personnel interested in. Once we have the findings from those surveys, then we'll develop materials that meet essentially what they're telling us they need. One of the trends that's emerging already is that they're interested in just-in-time training. Give me something that will take 5 or 10 minutes to review with a crew at the beginning of a shift, as opposed to sitting in a classroom for 2 hours reviewing infection control issues. Again, we still need to beta test, but one of the discussions is, does a field level paramedic need to know who developed measles, who developed the measles vaccine, how far apart should you receive the vaccine, how contagious it is or isn't, or is it more effective to teach field personnel if you have a patient with a rash and a fever, that should give you a high index for suspicion for transmission of something that is contagious, whether that's measles or some other pathogen. And then have materials that are more specific for individuals who want more information. But are there ways to focus on takeaways that really give personnel, this is what you need to do to protect yourself and your family. Make sure you're not taking something home to your kids. But you don't need to know who discovered measles to take those steps to protect yourself.
Right. Well, and while that information is critical and important, and I'm an education person, so I get with that. But that type of education should be addressed in initial education, not necessarily practical, continuing education, or to your point, the boots on the ground. How can I use this today? How can I use this in my shift? Not necessarily a history lesson on it. That's probably not as helpful in a safety briefing or in an initial response to something. So
right.
So it sounds like this is just ramping up. How long has this program been around? And then if you could, give a little bit of a history on what launched this program. I mean, obviously there's a need. As providers, we're aware of this, but something had to catalyst this jump into, we don't have anything like this, to suddenly we do.
So we're in year 3 of the project. We were very fortunate that our funder provided the initial 2 years for us to, get our feet on the ground in terms of background and some formative research to direct our future efforts. It's a little bit of a surreal story of how we came to be. I was at a listening session at the U.S. Fire Academy about COVID response, pandemic response, that had stakeholders from, some of the major professional national organizations. And in those listening sessions, what was repeated frequently is that personnel didn't get baseline infection control training, even if that meant how to put on and take off PPE, that topic really was not covered in initial training programs at technical colleges, community colleges. So at lunch at this listening session, I went online to grants.gov, where all the federal funding opportunities are posted. And in fact, there was one available. We had about a 3-week window to turn around an application, and were ultimately awarded the funds on my birthday. So there were lots of good omens built into the story.
Yeah. And there's nothing like having to rush through, a grant package to try to get something, 3 weeks, oh, no rush. Yeah.
We do a lot of things rushed. So that might have also been an omen of things.
So you mentioned that surveys are out. Could you, just give a little bit of information, number one, on kind of where they've gone and who you highlighted? And if there is a way that somebody who's listening might be able to search to see if the surveys are still open, that they might be able to contribute.
Yes, the surveys are still open. So they are targeted to field personnel. We're trying to get a fairly representative sample in terms of hospital-based systems, fire, EMS blended systems, volunteer and paid personnel. They are available on the USF ICER website. We're hoping to get some messaging out through you all so that the links are more visible. ICER in general, we've adopted sort of a everybody's welcome to the table approach. And that really is, we want to make sure to include whether it's field personnel or administrative personnel from any of those type of agencies. So that's where we are right now. We have a large group of student volunteers who are essentially cold calling departments to try to engage their administration and helping to distribute the link and the recruitment information. And we've paired up with some national organizations to try to get messaging out there. Again, we truly want to provide or fill in the gap, but we can't do that until we know where the gap is. The survey itself starts out with some really basic, what topics do personnel want, what aren't they getting, and what would motivate them to complete the training. It's not always, my agency requires it or my recertification requires it. Sometimes it's things like I want to keep my family safe and not take whatever's communicable home to my family. And so understanding those motivations helps us also get buy-in and, encourage personnel to complete the trainings once they're available.
Right. Well, I mean, we can talk a lot about, the personal aspect of it or individuals, coming in contact with something and why they might do it. But, like has impacted all of healthcare, what has happened with COVID and kind of the other side of COVID, they kind of smack people in the face to the reality of what could happen, and not on a single patient case by case, but, community wide. And people are starting to take notice who probably were like, yeah, that's not going to affect me. It's not a big deal, to, oh, wow, this is potentially a very big deal.
Yeah, I think even before COVID, it was starting, the issue of infection control in EMS was starting to come to the surface. And then, of course, COVID highlighted it. One of the other aspects that ICER is trying to do is to establish ourselves as a credible source of health information. So, lots about pandemic response is controversial. But one of the issues that personnel have voiced repeatedly is that information was constantly changing. And they would get one message about what they were supposed to do, and 2 weeks later, they would get a different message without necessarily an explanation of why the policy or why the information was changing. And so we're hoping, if we're able to establish that credibility, that when the next event happens, that personnel will come to us for credible messaging, what's been sorted through, what's been vetted, and what can be trusted in terms of either response or, direct data about whatever the pathogen is.
Right. So, of course, you mentioned community health and mobile integrated health and community paramedic programs are kind of blowing up as well, where people are spending more time with patients, versus the 5, 10 minute, 15-minute calls in the back of the truck. Are you guys, kind of paying attention to this trend? I'm sure you are, but it's a question for you to answer. So,
Well, and, part of the reason we left the surveys open so long was, again, to try to get as much representation as we could. It's one issue that applies to sort of any type of pre-hospital setting, but I feel like is more emphasized with community or paramedicine is once you're in patients' houses, what's seated there. We've all been in those houses that probably should be condemned, or where hygiene was not a top priority. And so, of course, that increases the likelihood of exposures to things like MRSA. And, if there's family members who are also ill that you're interacting with, that increases your risk. And so I think in some ways, community paramedicine might create some additional risk that we haven't really identified with. Of course, there's a role for community paramedicine in helping us to do some of this screening or providing care to ultimately contain the next outbreak. We know there will be another one coming.
Well, the other aspect too is just it's a different skill set. There are different items that are being done in homes where EMS professionals and paramedics have the skill set to do that, but in a home environment or the expanse of the home environment is a little bit different. You're like, I know how to protect myself on the truck. I know this routine, but a different environment opens up to different issues and different risks.
Yes, for sure.
So how did this program end up at USF?
So, because I'm at USF.
Okay, fair enough. I was just wondering how it located there.
I completed my initial training, my academic program at University of South Florida. At the time, I was a fire medic on a very busy ambulance in a growing suburban department, and would get swap time to go to class and come back. And so I did stay on after I have a PhD in communicable diseases. I did stay on with the department for quite some time after I had my degree. And during that time, I was an infection control officer. So, I had one foot in each world, and eventually the worlds overlapped.
I was going to say, if you weren't the infection control officer before, you suddenly were after the fact. They'd be like, we don't want this. This is yours.
Yes, for sure.
So, relatively new. You said you received a 2-year grant. What does the future hold for this? What are you guys looking to, or where do you see yourself in the end of 2 years, or going on in 5 years?
So we've had 2 years. So we have hopefully another 3 years, at least at this point, funded. And the goal is, of course, to find additional funding so that the project continues. We've been very careful in planning so that as we create things, there's sort of a legacy plan. We're not going anywhere when the funding's done. It's always more costly when you're in the development phase, but it's easier to maintain, after those materials are forward facing. So I'm here, ICER's here. We don't plan on phasing out when the funding ends.
Right. Well, something that I've always noticed when you have programs like this, or there's kind of a hometown feel, you went to school there, you're from there, that surrounding community tends to adopt that trend and is kind of, the petri dish of this is what we could be doing on a larger scale. Has that happened for you guys?
A little bit, not to the extent we initially thought it would. And I think part of that is that we don't have forward-facing training materials yet. Our initial plan that I think is still on the table is to do beta testing within the state, mostly as a cost issue. It's costly when we start flying or sending field personnel to travel to other states. We do have a plan for some of the other aspects of the project to do those virtually or provide online support so that on-site sort of liaisons are able to help us carry out those efforts.
Yeah. So how are you leveraging the online and the world of social media as well? Have you kind of come up with an idea on how that's going to go?
So we're slowly building our LinkedIn account, and we're hoping to team up with JEMS for some future information. One of the things that emerged from hospital-based infection control after the pandemic is we've sort of floated away from bare basics, things like hand hygiene. How do you take PPE on and off? Those sorts of issues. And so we're hopeful moving forward that we'll have some social media messaging and access with GEMS and some other organizations about those bare basics. As simplistic as it sounds, refreshing knowledge base about those things does make a difference. And so that's our starting effort. You don't necessarily need a lengthy webinar to talk about the proper way to do hand hygiene. And some of that messaging is just more effective through a social media platform.
Yeah. Well, that's great. So anything, we're wrapping up, anything that we didn't necessarily talk about that you're like, hey, I want to get this message out. This is kind of your opportunity to make the last pitch.
So I guess my last 2 points are, I did not mention a secondary mission of the project, and that is that we're out swabbing trucks and equipment to determine what pathogens are there, but also sort of hot spots. What are crews missing when they're disinfecting the back of their trucks? It's actually not, so far, it's not what you would anticipate. It's not patient care equipment. It's things like radio buttons and door handles, steering wheels. And so, of course, we're looking for departments that will let us come swab. We're not really interested in what is a particular department growing. We're looking at the bigger picture. And the last thing is, like I mentioned, we're very much adopting everyone's welcome to the table. And so if there are folks out there that have a fire and EMS background who have a true interest in participating, I would encourage them to reach out so we can roll them into the effort.
Well, that's great. Well, again, thank you for taking time out of your day to join us. Very important topic. Very interesting that we now have a group that is focusing on this, and the whole COVID kind of slapping everybody in the face, paying more attention to this, but just being out there so much and being able to focus on the pre-hospital aspect and not just the assumption of, oh, if it works in the hospital, it must work pre-hospital. If it works in a clinic, it must work pre-hospital. It's kind of refreshing to see that people are looking at that aspect.
Thank you. I appreciate the opportunity to chat with you today.
Well, we're looking forward to more messaging from ICER and your group, and anything that we can do to help, please let us know. And thank you again.
I appreciate it.